Hello, everyone, and thank you for being here. I'm very happy today to be able to offer this webinar with Dr. Jori Fleisher. Dr. Fleisher is a movement disorder neurologist and a assistant professor of neurological sciences at Rush University Medical Center. And she's also conducting a trial that she will tell you about called PERSEVERE. And I want you to know that there'll be time for Q&A after this. And I'm putting anyone who's not on mute, and you can unmute yourself during the Q&A. And without further ado, and let me put her on speaker. Dr. Fleischer, please. Thank you for being here.
Awesome. Thank you so much, Norma, and thank you all for joining. Thank you for all that you do, whether you are someone living with Louis, you are someone caring for a loved one with Louis, or who cared for a loved one with Louis in the past. Thank you, thank you, thank you. So let me just, oh, let me share my screen. I think Norma needs to grant me the power. Hold on. Let's see. All right. Thumbs up, seeing it. Yeah, okay, awesome. All right. So it is my pleasure to speak with you today. So as Norma mentioned, I'm an associate professor of neurological sciences, and at Rush in Chicago, I run our Lewy Body Dementia Center. I also run our Cure PSP Center, our Parkinson's Foundation Center, and I lead our clinic that's really focused on folks with more advanced symptoms who kind of need wraparound care. And so today I'm going to talk about Lewy body dementia, Parkinson's. Why is this so confusing? The naming is terrible. And kind of a little bit about what we know about outcomes, but I'm really going to spend the bulk of my time talking about caregivers. And I will use the term caregivers, care partners, carers interchangeably. I know some people identify really strongly with one of those and really do not like the other, but I will tell you there are many people who don't like caregivers and they want me to say care partners, but I've also been called out by using care partners and people saying I don't like that one either. So I'm going to try and use all the terms and I hope I make everyone happy. We're going to talk about what we know about Lewy body and Parkinson's care partners, what we don't know, and what we can do to support our care partners and those they love. So I always start any Lewy body related talk with, oh my God, this is so confusing. What are we actually talking about? Because the terminology is terrible. Don't hold it against me. I didn't come up with this, but I really, really like analogies and I feel like they're a helpful way to understand this. So, Lewy body dementia is really an umbrella term for two syndromes, dementia with Lewy bodies and Parkinson's disease dementia. And I think about this as a chicken and egg under an umbrella. Okay. So here's what I mean by this. When I see someone as a movement disorders neurologist, people are often sent to me for tremor, for slowness, for trouble with their movement. And I'm looking to see whether this person in front of me has signs of Parkinsonism, okay? Which means bradykinesia or slowness of movement and movements that get smaller as they make them. So in the clinic, we like to do our taps and our claps and we watch people walk. In real life, what that might look like is when you start brushing your teeth on one side of the mouth, you're okay. But as you get to the other side, it's tighter, it's smaller, it's more effortful to make those same movements. Or we start taking big steps as we walk, but then they get teeny, teeny, tiny, tiny, and we're sort of marching in place as we go on. That slowness and decrement of movements is bradykinesia. You have to have bradykinesia to have Parkinsonism. That's the one must have. And if you have bradykinesia and at least one of these other things, stiffness of the muscles that we call rigidity, a tremor, or changes in balance or posture, then we say the person has Parkinsonism. It's like saying they got a headache. Doesn't tell us which kind, just tells us the ballpark that we're in. Okay. For the sake of this analogy, we're going to say Parkinsonism is the chicken. Okay. Then people use the term dementia, and they often use this as a synonym for Alzheimer's because that is the most common form of dementia. In Alzheimer's, people suffer with a lot of short-term memory deficits. They're repeating themselves in conversation. They don't remember what they just had for breakfast. They don't remember talking with family the day before. But this Lewy body dementia is very, very different. So the changes that we see are far less memory and much more changes in attention and concentration. Someone who could multitask before now absolutely cannot. If they're interrupted in the middle of a task, they cannot find their way back to where they came. Concentration is really affected. Decision making and judgment can be very affected. The person who was previously the CFO of a multi-mega corporation now is really struggling when they're trying to make, calculate a tip or make change at a restaurant or at a store. Also, visuospatial processing. So even if there's stuff going on visually with the eyes, the challenge in Lewy body dementia is that once things get to the back of the brain, where visual information is processed and made sense of, that's where things are a struggle. So people have trouble with depth perception. They're putting things right on the edge of a counter instead of all the way fully there. They're misjudging as they're driving that the other cars are much closer or much farther away than they seem. Depth perception and contrast perception. So colors may be hard to distinguish, may be hard to kind of sort out patterns. People can see things in a pattern that isn't really there. So looking at some funky wallpaper and kind of seeing a face pop out, even though it's not there. Those are the changes in cognition and thinking that we see. And the other two big hallmarks are fluctuations. Now, in Parkinson's, we talk about fluctuations, meaning the medicines are working, the person is moving better. And then the medicine stops working and the person is moving less well. Those are motor fluctuations. But the cognitive piece is almost like someone has a dimmer switch in their brain for their level of alertness and their level of cognitive function. So one moment you're having a conversation with your loved one and they are sharp, they are on it, they can have that conversation the same as they could have 5 years ago. And 2 minutes later, you could almost see the fog descend. You could almost see sort of a dazed or glazed look. They can still speak, but their words might make a lot less sense. They might struggle to get the words out tremendously, whereas they were fluent and totally fine moments ago. It's like someone just nudges up against a dimmer switch and the person does not have control over that. Those fluctuations can be moment by moment, they can be day to day. And hallucinations. So seeing something more commonly, or sometimes hearing or feeling something that isn't really there. Those things are very uncommon in someone with Alzheimer's, but they define this Lewy body dementia flavor of dementia. Okay. So the dementia part is our egg. Okay. So as I torture this analogy, here's how we define these terms. If someone has the Parkinsonism, the movement changes, and at least a year later, they develop those dementia symptoms, we say that person has Parkinson's disease dementia. It's not a different diagnosis. It's not a new diagnosis. It's like saying they've got constipation. This is part of the Parkinson's. However, there are folks who develop the dementia symptoms first. And at some point later on, the movement symptoms, the Parkinsonism creeps in. If that's the case, or if everything happens together or within a year of each other, that is labeled dementia with Lewy bodies. And if that's not confusing enough, whether the chicken or the egg comes first or they show up at the same time, if you've got both the chicken and the egg, that is called Lewy body dementia. Are we totally confused? Yes, you are not alone. Movement people are confused by this. Cognitive people are confused by this. Everyone agrees that it needs better terminology, but that's where we are. So I talked about some of those core clinical features, and I just want to clarify that it can be really scary to talk about a lot of these things. And one of the questions I get a lot is, my loved one is not having hallucinations. Oh my God, what's going to happen? And when is that going to happen? And like anything in Lewy body dementia, whichever way we get into this, none of these things happen overnight. I joke that the brain cells are not unionized. They do not suddenly go on strike altogether 4:30 on Friday. This is a slowly progressive condition. If something ever suddenly changes, where from one day to the next, the person is very different, They've never had hallucinations before, and now they are. They were not falling before, and now they've just fallen 3 times in one day. That is always a sign of something else going on. 9 times out of 10, it's a urinary tract infection. So call your neurologist, but most likely your neurologist is going to say, call your loved one's primary care doc, get them checked for their urine, make sure that they don't have a cold, the flu, COVID, anything, because the symptoms will show up first in their Lewy body symptoms rather than the typical things we would expect for those other conditions. But all of these other changes are slowly evolving over time. So one of the scary things that people ask about is, what are the hallucinations going to look like potentially? And those can start as just someone seeing kind of a flasher or a floater, a little shape, a little blip of something, they blink and it's gone. Always check with your eye doctor, make sure it isn't actually a flasher or floater or something else that we want to treat in a different way. But sometimes people can feel a sense of someone being there in the room who's not. We call that a presence hallucination. That can also happen to folks when they're just sleep deprived. But as time goes on, people may see little animals, things that could plausibly be there. They might look out the front window and see some kids playing on the front lawn. Could be there, right? Or they'll see, a cardinal in a bush right out the front window. Could be there. Not something that a person might necessarily go, hey, I see a cardinal, and sort of check with someone else. But as time goes on, they can evolve to be much more complex. They recur over time. Usually we see the same things over and over and over. And it can turn into groups of people, more threatening images, and things that the person has less insight into. So if that's happening, please, please, please don't hesitate to bring that up to the person's treating healthcare professionals. We don't want to wait until it gets to the point that they're seeing groups of very scary people. We want to know about it, adjust medications before that point. So I mentioned the urinary tract infections. There are many papers out there, this has been studied for a long time, about what brings our people with Lewy body, with Parkinson's to the hospital. And there's kind of an almost tacit acceptance of these are the things that bring people to the hospital and there's nothing we can do about them. They're inevitable. The leading causes of hospitalization are falls, urinary infections or incontinence, dehydration, or metabolic derangements like being dehydrated and our sodium levels being way off, or potassium levels or calcium levels. Neuropsychiatric issues, hallucinations, delusions, agitation, profound depression or anxiety, and caregiver strain. Caregiver strain has been identified as its own independent risk factor and reason for people coming to the emergency room or the hospital with Lewy body. And the challenge is once someone with Lewy body is in the hospital, despite all of our best efforts, they stay longer than someone else who doesn't have Lewy body. They have more complications, and they're much more likely to be discharged to a nursing home than to be discharged home. So I, sometimes joke with my patients that I'm trying desperately to keep you out of the hospital because if you go in the hospital with one problem plus Lewy body, you could leave with 7. And it's not because anyone isn't aware and they're not trying, but the recognition and understanding of how complex people living with Lewy are and their different needs and how sensitive to medications is just not there. So here's the hypothesis. Maybe this isn't so inevitable in all the cases. Maybe falls, a lot of falls could be preventable. A lot of urinary tract infections, maybe we can't prevent them, but maybe we could catch them on day 1 or day 2 before they turn into sepsis, before they turn into a raging infection that requires IV antibiotics. Maybe we catch the hallucinations early before the person is profoundly agitated and upset. But to do that requires an educated, engaged, observant, supported care partner. So what do we know about Lewy body care partners? Okay, if you have not seen the Disney movie Encanto, I strongly encourage it, not just because I have small children, but it's a great movie. And this is Big Sister Louisa, if you're not familiar. Her superpower is she has superhuman strength. She literally hoists the world on her shoulders. And I feel like our Lewy body care partners have big Louisa energy. They are carrying everything, often unseen. So, what we know is more than 83% of community dwelling people, so people living at home, not in a nursing facility, with Parkinson's or Lewy body rely on family caregivers who are unpaid. And that adds up to 18.5 billion with a B hours of care every year. That if we actually paid for that, that would be $232 billion worth of care. We know that caregivers, even if their loved one is still working full time, caregivers lose their own direct income when they are still working because of the time taken off to get a loved one to the doctors, to call, to hassle with insurance and argue to get an MRI scheduled, to get someone to physical therapy, what have you. We also know, pound for pound, that when we compare care partners to a loved one with Alzheimer's versus care partners to a loved one with Lewy body or Parkinson's, the Lewy body and Parkinson's care partners have higher rates of caregiver strain, burden, and depression than our Alzheimer's care partners. And I said this in a paper once. And in any good peer-reviewed paper, a reviewer comes back and is like, well, I don't really know that I buy this. Why do you think this is? It's usually reviewer number 2. And I am incredibly lucky that I get to work with Lewy body care partners on my research team who weigh in on everything from ideas to designing a study to analyzing the data to interpreting what does this mean and what do we do about it. And our Lewy body care partners were astonished when reviewer 2 came back and said, why should we think caring for someone with Alzheimer's is any different from caring for someone with Lewy body? And it is the combined change in movement symptoms, in walking, in balance, in those cognitive changes that are less obvious and more challenging than just short-term memory, in the neuropsychiatric issues, the hallucinations, the delusions, and these non-motor domains. So constipation that can ruin an entire day, an entire week, urinary dysfunction. That means we need to be planning ahead anywhere we're going. Where's the nearest bathroom and how are we going to get there and is it accessible? And blood pressure drops. And none of that is predictable from one day to the next, sometimes even from one moment to the next. So trying to be a care partner and plan for all of that is quite different and takes a toll. And one of the ways that we decided we would respond to reviewer 2 is we did a really simple survey. We did a one-time survey of 182 people, care partners, to a loved one with Lewy body. And we just gave them a simple survey that's been looked at before that says, do you have yourself any of the following medical problems? High blood pressure, depression, back pain, other stuff that wasn't listed, all these things. So this busy, ugly table, what this shows is in the light gray column over here, this is among all comers. What's the percent who have that thing? So 38.5% of our care partners said they have high blood pressure. 37% have depression and back pain. But what we did was we also separated them out by age group. And we pulled what's the usual expected percentage of people in the 18 to 44-year-old age range or the 65 to 74-year-old age range who have high blood pressure. And so any of these black boxes tells us that Lewy body care partners in that age group have a far higher rate of that problem than we could just explain based on their age. So yes, high blood pressure increases with age, but it's more than that. Depression, back pain, this is more than we expect to see. And we think that this is related to caregiving. So I've told you that caregiver strain is its own risk factor for a loved one with Lewy body winding up in the emergency room in the hospital. It's also its own risk factor for someone winding up in a nursing home. And I'm going to get to the interventions. But basically, when I started doing some of this work back in 2010, 2014, there were no interventions that had been shown to be effective and really focused on care partners to loved ones with Parkinson's or Lewy body. There's nothing out there. And the very few caregiver interventions that have been shown to be helpful are in dementia, which usually means 90+% are Alzheimer's. And these are costly, big, heavy interventions where you sign up and it means a nurse is calling you 3, 4 times a week, going through checklists, doing all kinds of things, and you have to log on to something and you're filling out surveys, you're doing all kinds of stuff. And they may be helpful, but they're not sustainable in the long term for care partners or financially for systems to be able to offer this. So I see patients in clinic all week long. I'm going to run to clinic right after this. And I can guarantee you that someone today will say, Jori, I give up. I'm ready to have you send someone to me. I cannot do this all on my own. You can send me someone, right? And what they mean is a paid caregiver, whether that's for a couple of hours in the morning or that's I need someone 24/7. And every single day, I have to break someone's heart and tell them that our system does not cover paid caregiving. Medicare, regular insurance, Medicaid, hospice, none of them cover paid caregivers. So unless you are someone who bought into a really, really good long-term care plan way back when, which is really most of the time no longer offered, this is almost entirely out of pocket for most people. It is very expensive. So figure about $30 an hour at minimum, higher and higher cost of living areas. There's a very high demand and low supply. There's a very high turnover rate and very high burnout rate among paid caregivers for a whole host of reasons. It was bad before COVID. It got worse post-COVID. And I would venture a guess that as things are changing in our current political environment, knowing that many of the folks who are paid caregivers are women, women of color, highly underpaid women, and often immigrants, that the supply may worsen even further. And they have no training. They typically have no training in Parkinson's, in dementia, in Lewy body, and in end-of-life care. So what do we do? This is not a sustainable option for most people, right? And I feel like every day I have to tell people, I'm really sorry, the cavalry is not coming. And that is not what I'm leaving you with today, okay? So what can we do? Hopefully that is why you logged in. So flashback in time, as when I was a brand new faculty member, I happened to be in New York at NYU, and I had the amazing opportunity that one of my supervisors had mentioned offhand to one of his patients, I'm losing my sweetheart patients, not to death, but I'm losing them because they're not able to follow up. They're becoming homebound, and it is too hard for them to get to us. Us being the movement disorder neurologist, the general neurologist, the cognitive neurologist. And if we're supposed to be the people to be able to advise folks on what to do, and they can't get to us, they are not seeing their primary care doctor, so it's okay and it's being handled. That's simply not true. And so he said, I really wish there was a way that I could go out and see people. And through an amazing generosity of a donor, they said, okay, go build a program. And so I showed up and they said, hey, you're a new faculty member. You're all warm and fuzzy. How about you go do home visits? And we said the way to do this is not just sending out a doctor, because I will tell you that what I have to offer is the least important. I went with a nurse and a social worker. And together as a trio at every single visit, we did over 400 visits across all 5 boroughs of New York City. I did everything I would do in clinic. We talked about the meds, we talked about symptoms, I examined them, but the really important stuff was our social worker was asking, what services are you currently receiving? What services would be helpful? What does your social support network look like? Are there kids? Are there nieces? Are there nephews? Are there other folks in the picture who could help? Is there a faith community that you belong to that's meaningful to you? Could they be pulled in? Are there friendly volunteer services that we could pull in? Are you getting physical therapy? Do you need to talk with a counselor? Let's find those in the community and pulling that in, not just for the person with Parkinson's or Lewy body, but also for the care partner. At the same time, my amazing nurse was going, take me to the meds, not just asking, hey, are you still taking the things that you were taking last time I saw you? Yes, gold star. actually show me how things are organized. Show me what this looks like from day to day. And for some folks, that was a beautifully organized tackle box, right? With the 17 different compartments and alarms and the things. And amazing. And for some people, it was a gallon-sized Ziploc bag into which their care partner had dumped all the bottles. And when they looked at the clock and went, oh, yeah, we were supposed to take something, we fish around for the little yellow pill and we take it out and we go on our way. For another patient of mine who lived by themselves with dementia, she had two white paper plates on her dining room table. One had the bottles of what she was supposed to be taking. The one next to it had the bottles of what she was not supposed to be taking anymore, or extra pills that Optum or Caremark sent her a 3-month supply. So they were all on the table together. We also walked around the homes of our patients with their permission. With their permission, we opened up the fridge and the pantries because Uncle Google and a lot of us in white coats spend a lot of our time thinking about protein interacting with levodopa. What's far more important is, are you eating? Do you have access to healthy food? Or are you choosing between medications and food? And that is unconscionable. So for a lot of our folks, the biggest thing that we did, the most impactful thing, was get Meals on Wheels in the house. Is it the most delicious? Is it Michelin starred? Absolutely not. But can they then afford other medications or to go to therapy? Yeah, and that's worth it. So we did all these visits. We saw people often every 3 to 4 months, some for years. And what we found was in every other study of Parkinson's, as time goes on, disease progression worsens, function worsens, and quality of life goes right down alongside with it. But in our home visit patients, although their function worsened, quality of life stayed the same. And we thought maybe we're onto something here. However, we also measured caregiver strain. And we found that despite the home visits, caregiver strain continued to get worse. It was quite high among these folks who were homebound with advanced PD and Lewy body. So we knew that we needed to do something more for these folks, that home visits alone were helping our patients, but were not enough to mitigate caregiver strain. So we tried to come up with what could we do, and wondered whether connecting caregivers together one-on-one could ease the journey in the isolation, not to take the place of a support group, not to take the place of a Facebook group or a Reddit group or a smart patients group, but as an addition. And so we came upon this idea of peer mentoring, which at that time, back 2013, 2014, had been studied in a couple of different areas, initially in Alzheimer's caregivers. And what they meant by peer mentoring was we got a group of folks who used to care for a loved one with Alzheimer's disease. Their loved one has passed, but we still have their info. And we reach out to them and say, hey, would you mind talking with someone who's going through this journey now? Whatever is helpful. Just kind of be a sympathetic ear to them. And in some of the programs, they gave them some training, and some of the programs not. In some of the programs, they gave them a curriculum to talk through. In other programs, they were like, nah, you do you. Talk about whatever you want. And the data was sort of meh. When they look at the numbers to see, did this really work for people? They didn't see a lot of change in caregiver strain. They didn't see a lot of change in sort of the surveys. But when they asked people, how was this for you? And let them say what they wanted, the data was overwhelmingly positive, not just for the people who were actively caring for a loved one, but those who had previously cared for a loved one found a sense of closure. They found a sense of benefit in this and realized, like, whoa, I didn't actually think that I learned as much as I did. I didn't think I had as much to offer, but it turns out I actually learned a lot. And since that time, peer mentoring has been studied and found to be helpful in all of these groups. I won't read these all out. But what I think is most compelling, what made me say, all right, fine, we're going to pull the trigger, we're going to try and do this, is I cannot imagine a group of care partners who should have more reason to run screaming in the opposite direction from ever being part of this community again than parents who have lost a child to cancer. And there are studies showing that parents who have lost a child to cancer will willingly offer themselves to other parents actively going through that process to make that journey better for them. in a way that they hadn't had it on their own. So if that can happen in that community, that was the thing that sort of made me say, okay, let's try this. So we built on that home visit intervention, and I had moved from New York to Chicago, and we built a program. We got funding from the NIH, and we enrolled 65 pairs of people with Parkinson's disease, most who would qualify as Lewy body dementia because they had PD dementia, and their care partner. And they received 4 home visits, just like I described, over the course of a year. We had started to incorporate some telemedicine. So I was in my office, unfortunately. I would have much rather been in the home, but my social worker and my nurse were there. We brought the internet with us so that no one had to remember their Wi-Fi password. But what we added in between was between the second and third home visit. So for about 16 weeks out of the year, we had trained 34 experienced care partners to be peer mentors. We brought them to Rush, we trained them, we created a little handbook that was about 40 pages with these topics, kind of what's the role of a mentor? How do you set boundaries? It's not okay for your mentee to call and say, hey, I know you actually live 10 minutes away and my loved one's on the floor and I can't pick them up. You want to come over? No, not okay. But what could you offer them at that time? I'll stay on the phone as you call 911, right? So training people on how to be a mentor, how to be an active listener. And we matched them up and we waited to see, would this actually work? And lo and behold, these 34 people went through training. Of our eligible caregivers, 51 completed. And we asked them to call each other once a week for 16 weeks. On average, they came out to about 11 calls over 16 weeks, and we did not tell them how long to talk. And the average was 30 minutes with a range. And at the end, we said, how satisfied were you just with this peer mentoring thing, with just talking with someone? And the satisfaction was about 91%. And what we found again in home visits over the course of a year was not only did home visits stabilize quality of life in our patients, but in some areas of quality of life, things actually improved compared to our control group. But when we added in peer mentoring, we found that caregiver strain stabilized, whereas in the control group, it worsened, just like every other study has shown that it will. So we thought, okay, we're onto something. This might have legs. So we moved that on to the next study, and I titled that study Learning to Persevere. So, small aside, I was partially raised by my maternal grandparents. And in addition to my mom, their older daughter, they had a younger daughter who was born with severe neurologic impairment. And I remember vividly my grandmother, Ro, teaching me the word persevere when I was 4 years old. I don't know why, but it's one of those core memories. And so it's always been a word that I associate with her. And the dictionary definition of persevere is to continue in a course of action, even in the face of difficulty or with little or no prospect of success. But when you're writing a grant, you are more likely to receive the funding and be able to do the work if you have a catchy acronym. So if you squint, peer mentors, support, and caregiver education, you can kind of get all the letters for persevere. So we took this peer mentoring idea. We did a bunch of focus groups first. We showed that 40-page handbook that we used to train our mentors to the mentors again, to the mentees in that first study, and then to a bunch of new to us care partners and said, here's this handbook. Is this even helpful at all? Do you want a handbook? Are there topics that we're missing that would be helpful? Or is everything that you can find on the internet sufficient or from your healthcare providers? And oh, did they have thoughts? And so we went from a 40-page book to basically a 400-page book, created entirely from scratch, trying to pull together better ways to explain all of the symptoms, to identify, yes, this is part of Lewy body, instead of someone having to go in circles and find 1,000 specialists and try to figure out what is causing this. We made the program entirely virtual. We opened recruitment up nationally. So this was all during COVID. We partnered with the Lewy Body Dementia Association and Parkinson's Foundation. They sent stuff out to their various email lists and Facebook groups. We wound up recruiting and training 36 new mentors, so experienced Lewy body care partners from all across the US. They had about 6 hours of training online with live stuff, with some videos, with all kinds of things. We did question and answer sessions with prior mentors so that they could get a sense from the horse's mouth, what was this really like? And then even though other studies from peer mentoring had said it doesn't matter how you match people up. If they've been on the journey, they've been on the journey, it's all about the same. That struck us as incorrect in Lewy body. And so we decided we would ask people if they had preferences about who they were matched with, and we would do our very best to try to match them appropriately. So, how important is it to be matched with someone who shares the same role, meaning you're a care partner to a spouse versus an adult child caring for a parent, or a sibling, or a neighbor? How important is it that your mentor is of the same gender or shares a similar racial and ethnic background? How important is it that your mentor has gone through the grieving process? Because maybe you feel like you are closer or in a later stage and you want someone who can tell you what that was like. And then we tried to optimize and match people up as best as we could. I mentioned we went from a 40-page book to over 400 pages. Not all of it was created totally from scratch. Some of that was people saying, we want other stuff that does exist online that you tell us is trustworthy and we can actually believe in. And we said, great, we'll give you a link. And they said, I don't go on the internet. I don't use a computer that much. I want something at my fingertips. So we printed it out and we put those in as appendices at the back of the book, which led to a book that people could bench press in their spare time and build their strength training. But these were all of the topics that we heard from people. We need reliable information about all of this. And it became really clear that there were questions and topics related to symptoms, but there was so much about being a care partner, period. We got so many people writing in and saying, Jori, I feel angry all the time. This is not who I am. I feel so much guilt that I'm not. I feel so much guilt because I am, whatever it is, and feeling alone in that. And they are not alone in that because I can tell you that's what I hear every single day in clinic and in these emails and in these messages. So we put it out there to normalize it and validate it and help people know that they're not alone and it's safe to talk about. And what we found was we put everyone together and we said, okay, week 1 begins now. We sent them all their books. We matched them up with their mentors. What happened? Despite active caregiving demands, or many of our caregivers going through the grieving process, they prioritized learning to persevere. So our 30 pairs completed over 400 calls. I told you last time we asked them to talk every week, and they talked about 11 times out of 16 weeks. This time, they talked 15 times on average out of 16 weeks. We didn't tell them how long to talk. Far be it from me to say how much time you have. And on average, people talked for 45 minutes. Some of our care partners talked for 2 hours a week with their mentors. 100% found the calls useful. 100% said, I would recommend this to other care partners. And we asked folks, would you do this again in the future? 90% of our mentors said yes. And what I thought was really interesting was we asked the mentees, and 40% of our mentees said, I would do this again as a mentee again. I feel like it would be helpful to hear from another mentor and to go through this again. 10% said, I'm good right now. But 50% of the mentees said, I'm ready to pay this forward and be a mentor to someone else, which is incredibly compelling. And we did a bunch of surveys and we found not only did the mentees improve their knowledge and their attitudes towards caring for a loved one with dementia and their confidence and their skills, but actually the mentors improved their knowledge too, which was really encouraging. So we did a bunch of further work on this to try to make it better with lots and lots of feedback from Lewy body care partners all across the country. They said, we want even more support for the mentors. You should have office hours. You should have monthly meetings where the mentors can come together in a Zoom and talk with each other about what they're going through and what's been successful and not. Make it 12 weeks instead of 16 weeks because holidays and vacations. Talk more about grief. Talk more about hospice, talk about brain donation, talk about nursing facilities. So we did. We had also tested out virtual reality training in home healthcare professionals, that there is a program that was created to help people caring for folks with Lewy body in a nursing home, for example, to have a better understanding and more empathy about what it is like for the person with the diagnosis. And so we tested this out. We showed these videos to care partners and said, look, we know that this could be too much. This might be triggering. This might be upsetting. Do you think there's any value to this? And sort of the uniform response was, oh my God, is this actually what my loved one is seeing? Is this what they're feeling? I had no idea. This is totally different than reading about it, than talking with someone about it. And so we added this in to the curriculum as well. And so we also heard, this is nice. I can bench press this 400-page book. It is way too much. Make it a website, make it a PDF. So if I'm searching for something, I can find it way easily. So we did all of that. And we applied. And even though the National Institutes of Health doesn't do a lot of caregiver grants, doesn't do a lot of Lewy body grants, let alone both, they funded this grant. And so Persevere was funded and started enrollment just over a year ago. We launched enrollment in like May 6th of 2024. And what this is that same idea. So it is a totally national, totally virtual. All of this is on your own time. It's online or by phone. And it is a randomized controlled trial of this intervention that we have tweaked and made better as much as we can with input from hundreds of care partners along the way. So this is open to anyone who is a family or friend care partner of a loved one with Parkinson's, with any changes in their memory or thinking, even if they don't have a formal Parkinson's dementia diagnosis, anyone with Lewy body dementia, anyone with dementia with Lewy bodies. Basically, if you fall anywhere under the umbrella, if you've got a chicken and egg, even if your doctor hasn't said that you've got the chicken and the egg, we take the care partner's word for it. We are not getting medical records about your loved one. We are basing this on what you as a care partner tell us. That is good enough for us. We are enrolling both current and past family care partners. And the way that we kind of divide people up is if your loved one has passed, or if you're still caring and they've had cognitive changes for 3 or more years, you qualify to be a mentor. If you're caring for someone and their cognitive changes have been going on for less than 3 years, you qualify as a caregiver. And the caregiver group is randomly assigned to one of 2 arms. Everyone gets something. We have to kind of have a control group to be able to see whether it really works. But we were not okay with saying, you guys get everything. And control group folks, sorry, you're out of luck. Hang in with us and answer all of our surveys. So what this looks like is, as I mentioned, everything is virtual. It is completed at a time that's convenient for you. It's about 9 months of participation, all told, but it's not all at the same time. And it's not a ton of involvement. So for the mentors, we do mentor training in chunks. Once we have enough people, we'll sort of send out dates and say, all right, we're doing a training. Tell us which dates work for you. And then once you're trained, you're kind of in our pool. You're waiting to be matched. Our caregivers, and this is the much bigger group, once we get 100 people at a time, we randomly assign them to either the active group or the lighter intervention group. And then they get told, okay, you're in this group. Week 1 is going to start on this date. We send everyone out what they need to know. And then we send you info every step along the way going, all right, this week is week 1. You should be doing this. When it's one of those active weeks, it's maybe about an hour worth of stuff, if that. So the entire intervention is 12 active weeks. And then for 6 months after that, we just check in with you every 2 weeks with a quick online survey. It should take about 5 minutes. This is the QR code for folks who are interested. I will show it again in a little bit. If you follow that QR code, it should get you, or this link, that gets you to a page. We actually had lots of bots and spammers. So I'm sorry we had to put in one of these annoying reCAPTCHA things. So just tell us you're not a robot. And then it should take you to the main page. There's a video all about the study if you're not bored of hearing me talk already. More importantly, there are videos from prior mentors and mentee participants talking about what it was like for them. Then it will get you to the survey. And if you complete the survey and you qualify, that automatically pings my team and says, there's a person, they qualify to participate. They will follow up with you by phone to do a quick screening and make sure any questions you have, we answer before you sign on the electronic dotted line. All told, we are recruiting 150 mentors and 500 caregivers from all across the United States and US territories. So if you live in any US state or any US territory, if you have friends in the Lewy Body Network, we know that there are a lot of areas of the country where there is very little. Please share this with them. We've tried to get information out to neurologists, but if you live in some of these gray states, there's no neurologist to get it out to. And so you may be very much on your own. If you know folks who live in the Virgin Islands or Guam or Samoa, we have resources for them. We are ready for them if they can find us. We're trying really hard not only to sort of cover the entire US and make this available, but there are particular groups of care partners who tend to not be reached most of the time. Male care partners are really few and far between in a lot of Lewy body research. We want to make sure that we reach them. Care partners of color are really underrepresented tremendously. We want to make sure that they know that we are here for them and that we have both mentors and care partners. We also know that folks in rural areas are really underrepresented, and so we are trying to reach them as well. So here's that QR code again if you are interested. We're also on clinicaltrials.gov. We're on Fox Trial Finder. We're on LBDA. If you've heard about Persevere in 1,000 different ways, I'm sorry and thank you and please be patient. You can email us directly. I have an amazing small but mighty team at persevere@rush.edu. And one of our brilliant care partner advisors said to me, Jori, people are getting health information on TikTok. You need to be on TikTok. And I said, with all due respect, I am too young to retire and I am too old to be on TikTok. And she said, I don't care. That's where people are getting information. Put stuff out there. So if you are on social media, we are on TikTok. We are on Instagram. Please follow us. So with that said, I will just conclude with saying that Lewy body dementia is common. It is a growing cause of dementia and disability worldwide. One of my mentors describes it as the biggest disease you've never heard of until you're in the community. There are identifiable and potentially preventable or manageable causes of hospitalization, which we think we could detect by trained and empowered caregivers. And our Parkinson's and Lewy body caregivers have higher strain and burden and depression and back pain than care partners for those with Alzheimer's disease. The caregiver strain is its own risk factor for our loved ones winding up in the hospital and nursing homes. But we think that this could be modifiable with peer mentor-led educational interventions. And that despite all of the things on your plate, our care partners willingly share invaluable lived experience and train as mentors to serve as future caregiver peer mentors, creating a pipeline. So I told you before that I have to break everyone's heart and tell them the cavalry isn't coming in terms of our healthcare system. But what I have learned is that the cavalry is all of us, supporting each other, whether that is in a webinar like this, a support group, whether that's just walking up to someone that you see shaking or shuffling and going, do you need help? Are you getting the care that you need? Let me tell you about XYZ. So thank you, thank you, thank you for being part of this community, for all that you do. I want to acknowledge my amazing teams and my advisors and my mentees and the incredible support that we've gotten. My kids who encourage me to always look forward to tomorrow and figure out how we make it better. And importantly, to my grandparents. So when I went into movement disorders, I did it because, as I mentioned, I grew up with an aunt who'd been severely affected by neurologic disease and other family members with neurologic disease, but we didn't have movement disorders in my family. So I thought, well, this is a safe zone. Lo and behold, flash forward years and years, and my beloved grandparents who helped raise me developed Parkinson's and Lewy body. So I know this on the doctor side. I know this on the researcher side, but I have been there in the room at 3 a.m. when someone is hallucinating, when someone is mistaking someone for someone else. I get it and I see you and I have the most respect and awe for all of you. So thank you so much. And thank you to Norma for the opportunity to speak with you all. And with that, I will stop sharing.
Jori, thank you so much. That presentation was extremely informative. It was one of the best I ever heard, and I've been doing this many years. Not that I wouldn't expect that from you, but I'm sure there are people who may have questions, so I don't want to take the time and who, if somebody can raise their hand or let us know. Anybody have a question for Dr. Fleischer?
Norma, I have a question. This is
Yes,
Tammy.
yes,
Uh,
Tammy.
it's regarding managing medication and getting a skilled team on board. I've had the problem once we are had the psych eval to uh, that we have Lewy bodies possibly, and the medication, getting the doctors on board to get the right medication. Um, because he's on some anxiety medication that he shouldn't probably be on, based on what I've read, and that's bupropion. And so finally, I got someone to listen to me, and we're starting to wean him off and perhaps get him on the Exelon. But it was a 6 weeks battle.
I wish I could say that your experience was singular. I think it is more common than not, and it could be a whole host of different symptoms that people really struggle to find someone who's going to listen to them, who's going to hear what's going on and hear the concern and have the specialty knowledge to be able to treat it appropriately. Sometimes the right treatment is taking away medicines that are causing the problem or exacerbating the problem. And sometimes then step number two is let's see where we are now that things are a little bit cleaned up. And now let's add on a more appropriate medication. I think, I tell people if you have a healthcare provider who's insulted by the idea or the question of getting a second opinion, that's definitely someone you should get a second opinion about, right? Like none
Right.
have the answers, have all the answers, right? And I was just finishing up slides. I'm talking sometime in 2 weeks to primary care docs and geriatricians about Lewy body dementia. And even though 85% of the time people with Lewy body dementia present to a non-neurologist first, the people you are presenting to don't have this knowledge.
Yeah, you're right. Yeah.
And if they hear anxiety, they may just throw Klonopin at someone, right? And
Right. And that's where we are with
yeah,
this, and the anxiety with the hallucinations really exacerbated when we had an incident where he couldn't go to our master bathroom. He had to go to the powder bathroom, and going there at night with the hallucinations,
it's
it
a
became
disaster waiting to
scary.
happen.
And so now he has anxiety with everything. Now he just feels anxiety about anything, where he wasn't doing that before.
I'm
So is
so
that,
sorry you're going through
I
that.
know, is there something, is there a medicine or something that with the anxiety, since we're getting him off of that pro, bupropion, that would help him to not be so anxious? Or is that
So,
just part of the illness?
so I can't comment on like individual folks because without knowing and being able to examine, right? So I won't say here's the right medicine for you. But what I will say is there are better choices for everyone, right? I mean, I have some folks where bupropion works beautifully. Like that's an okay medicine to use for anxiety in some folks. So I don't want to, there are lots of medicines that, we can use depending on the person, and it's a lot of trial and error. There are
Okay.
very few medicines that we absolutely cannot use. The absolutely cannot use Haldol, haloperidol. If you can remind your loved ones, healthcare providers, list Haldol as an allergy in their medical chart.
Mm.
Get a medical bracelet. Put Haldol as an allergy. Okay? Not because it's an actual allergy, but because it is strongly contraindicated. So the heavy duty, old school antipsychotic medicines, which do work well for other older adults in case of emergency when we need them. But that's what the emergency room reaches for. When someone is agitated, out of control, something's going on. And we absolutely cannot give those to someone with Lewy body. And even some of the newer antipsychotics are billed as sort of, not Haldol. Many of them are just as strong. Um, so, you know, there are better choices and there are worse choices in sort of, any category. So I would say, talk with a neurologist, talk with a geriatric psychiatrist if you have access to one, see a geriatrician if you can have access to a geriatrician. Often our geriatricians are unbelievably amazing if you're lucky enough to be able to find one and get in. Um,
Thank you,
you know,
Jory, for that, because I know Tammy and I have talked, and I suggested she find a movement disorder neurologist if she could.
yeah,
Sometimes a lot, I'll say for other people, unfortunately, are not ready for a geriatrician because they're too young. That doesn't
yeah.
necessarily apply here. But I just wanted to give anyone else who had a question for you. I didn't want them to miss the opportunity. Amy? Yes.
Hi, thank you so much for doing this. It's a wealth of information. I'm wondering if you could address the Lewy body with pain. Like, is pain a symptom of Lewy body? Is it, my husband has severe migratory deep muscle pain, and we spent 5 years trying to figure that out, and nobody has ever figured it out.
So here's my take. Yes, it's part of it. What I will say is when I was even in fellowship, 2012 to 2014, there was minimal recognition at that time. And the party line then was basically there's no pain in Parkinson's. In the last 10 years, there's been increasing recognition of, oh, there's absolutely pain in Parkinson's. There are at least 4 different kinds of pain in Parkinson's. People can
Okay.
have, sort of stiff muscle, achy pain. They can have dystonic pain where the muscles are cramping, especially if the meds are wearing off. They can have neuropathic, like sharp, radiating sciatica kind of pain.
Mhm.
And they can also have what's called central pain, which is deep, vague, miserable, hard to describe. It could be anywhere. It doesn't respond to a lot of different things. There's not very much at all written about pain in Lewy body. And I firmly believe this is really all part of the same spectrum. It's the same protein going wrong underneath, forming the same clumps of garbage bags of misfolded protein in the brain in the same places. The question is just the timing and the chronology. The symptoms are all the same. So, yes, I think that the pain is part of it. I would, if you're seeing a neurologist and they're not responding, I would ask about seeing either potentially a pain medicine specialist or palliative care. And I just want
So,
to, yeah,
no, I'm sorry. Yeah, so it's interesting that so my husband is currently in the hospice at home dementia program. And he only got diagnosed with Parkinsonism last December, but I can go back 9 years from when he started having a sleep disorder that got diagnosed as narcolepsy, atypical narcolepsy. And I can go back and say, okay, that was the beginning. Now that I know more about Lewy body, and he has not been officially given the diagnosis of Lewy body, but he has been given the diagnosis of Parkinsonism.
right.
And I feel like now that we finally know what's going on, and I'm going back and connecting all the dots and saying, oh my gosh, I see everything now going back. He's in hospice, which is no further treatment, mainly because of his pain because he can get better pain management through hospice, which we've been to a pain specialist, neurologist, and I've asked everybody if pain could be part of this, and they've all said not likely.
Well, I'm glad you just got the real answer, Amy. And I can tell you 100% of people who call our helpline in the support groups say, looking back, they know that these symptoms were way back. So I just wanted to say that too. And hospice and you have to have the doctors who know what they're speaking about. It has to be a movement disorder neurologist, I find, just like Dr. Fleischer is. So it's very frustrating. I know it's completely frustrating.
You are so not alone. I mean, I feel like everyone sort of describes this, we went searching, we went to this person, we went to this person, we went to this person, and no one knows, and no one knows. And then finally they said Parkinson's, or finally they said Alzheimer's. And then later they said this. 85% of the time, or sorry, 80% of the time,
What did you
study, people are misdiagnosed.
Yeah, it's something about Lewy body. Go ahead.
No.
Okay.
Thank
you so
Tell me.
Yeah, there's somebody, okay, let me just mute her. Thank you. And Amy, I just want to suggest again, we know we have the support groups in addition to the PERSEVERE study. So just know that maybe I think Dr. Fleischer has to go. I don't know if we have time for any more questions.
I
She
could
has
probably do one more
patients.
question. And then
Okay, who had one more? Who had their hand raised? Is there one more?
I see Nancy with her.
I do. I just wanted to respond a little bit to Amy. If he hasn't been diagnosed with Lewy body, I would go after that because there may be different types of medication they may offer if they know it's Lewy body. Wouldn't you agree?
I would.
Yeah.
And I think there's a misconception that once someone is receiving hospice services, they can't see a neurologist anymore. That is not true.
Oh, okay.
That is not legally correct. Things get challenging because hospice agencies, I mean, are wonderful and are doing tremendous work with a very limited budget. And so, have to say, we can cover this, but we can't cover this. So physical, occupational speech therapy usually cannot be covered. Really expensive medicines cannot be covered. But they have to cover specialty care that they're not able to provide, and they're not able to provide Lewy body expertise. We're just not.
Okay. So
Thank
that's
you.
really good. No, thank you.
Yeah, absolutely. And Amy, I just would like to say in closing too, that please make sure, because I know they give you a pack for the refrigerator that has morphine and other things. It usually has Haldol in it. Please make sure that they don't have Haldol in there. I can't tell you how many hospice agencies don't know that it shouldn't be given to a person with Lewy body.
Okay. Good to know. Thank you.
Okay.
And I just put this into the chat in case that's helpful at all for anyone. We've tried when myself or my colleagues give any other talks anywhere that we think might be helpful for folks in the public. I've tried to ask them please send me the link and we will post it on our website so anyone who wants has access to it. It is not meant to be the Jori show, but right now that's most of the videos that are on there, so I'm sorry. You can use me instead of a sleep meditation and I will just put you to sleep. But that's on there, and here's the PERSEVERE site as well too. So.
That's great. I want everyone to know that I'll be sending out an email so that everybody gets it in our newsletter in June, and it'll have the recording. It'll have the link to the PERSEVERE study. It will also have the email for Rush University Medical Center so that you can get more information on this. I want to thank you, Dr. Jori Fleischer, for being with us and for sharing so much wonderful information that people really need. Thank you again for taking the time. Okay.
Thank you, Norma.
Thank
Thank you
you.
all.
Everyone. Thank you.
Take care. And yes, I'll send you my slides, Norma.
Okay, terrific. Thank you.
All right.
All
Take
right.
care. Bye-bye.
Bye. You too.
Bye.